Hi, everyone. This is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And I'd like to thank ESGO and IGCS for their support of our journal club. We're really very excited about this journal club and the discussion of this particular topic as well. Just before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's journal club. We're recording today's discussion, and the recordings will be made publicly available. Participants with a camera turned on may appear in the video recording, so we ask that everyone please keep your microphones muted so everyone can hear the presentations. If you're having any difficulties or questions, please send a message in the chat, and our technical team will assist you in this matter. We will have time for questions and answer, and certainly encourage all of you to submit your questions via the chat function throughout today's session. So with that, I want to again welcome everyone to the Journal Club for this month of December. And this month's lead article is Optimizing Patient Selection for Secondary Cytoreductive Surgery in Recurrent Endometrial Cancer by Virginia Vargiu and Francesco Fanfani from the Gemelli Hospital in Rome. So we're really very, very happy to have this opportunity to discuss the article with both of you. We certainly encourage all of you to write in your questions. And we're really, again, very excited about listening to the results of the study and engaging in these discussions. So Francesco, Virginia, welcome. And thank you once again for accepting our invitation, and thank you for submitting your work to the journal.
Thank you, Pedro, for this introduction, for this invitation to join you with our data about the role of selection patients for secondary cytoreduction in endometrial cancer. We are very excited to be a part of your group.
Thank you.
Thank you, Dr. Ramirez. So my name is Virginia Vargiu, and I'm a gynecological oncology surgeon at the Policlinico Gemelli in Rome. So today I'm pleased to present our recent study focusing on the role of secondary cytoreductive surgery in recurrent endometrial cancer and the factors that help refine the patient selection to achieve an optimal outcomes. So recurrent endometrial cancer remains a significant clinical challenge. Secondary cytoreductive surgery has the potential to offer meaningful survival benefits, but its indication is strictly dependent on the likelihood of achieving complete breast resection. So in this context, the study I'm presenting today focuses on three key areas. One is identifying the predictive factors for achieve complete breast resection. Then we wanted to propose a scoring system to guide the patient selection and evaluate the feasibility and morbidity related to the secondary cytoreductive surgery. So this study retrospectively analyzed 331 women with recurrent endometrial cancer across 3 Italian centers. After careful evaluation at multidisciplinary tumor board, the patients were addressed to different treatment options. So, and then we categorized the patient in 3 groups. Patients addressed directly to medical treatment, and patients addressed to surgery. All the surgery began with a diagnostic laparoscopy, and patient could go on with the bulking surgery or just receive a diagnostic laparoscopy, and then that would proceed with other medical treatment. We found differences among these 3 groups in terms both of clinical and recurrence characteristics. Patients undergoing cytoreductive surgery were usually younger. I think we can, yeah, okay. So they were usually younger, had a lower BMI, had a better performance status, and fewer comorbidities. And then in terms of recurrence patterns, secondary cytoreductive surgery, patient with undergoing secondary cytoreductive surgery had a higher rate of single-site relapse and fewer cases of peritoneal or mixed recurrences compared to the other 2 groups. What we found is that we identified 4 independent factors that are strongly associated with achieving the complete breast resection that was our goal. We identified an age less than 65, the single-site recurrence, the lymphnodal relapse, the hematogenous relapse. Using these predictors, we built a predictive score. And we assigned a score of 1 according to the beta coefficient found at the multivariate analysis. And we built a score that ranged from 0 to 3. This scoring system demonstrated a good performance, especially with the higher score. So patients with a score of 2 or 3 had a high likelihood of achieving complete gross resection with success rate of 86 and 93% respectively. On the other hand, patients with a score of 0, that represent patients with multiple metastatic size, peritoneal or mixed recurrence, and age over 65, had a significantly lower chance of achieving complete gross resection. While the scoring system showed an impressive positive predictive value of 87.8%, the negative predictive value was 43.8%. That means that some patients who might benefit from surgery could be missed. To overcome this limitation, the authors suggest integrating diagnostic laparoscopy, particularly for patients with an intermediate score. So this two-step approach enhances the predictive accuracy and ensures a more refined patient selection. Looking at the feasibility and morbidity of secondary cytoreductive surgery, despite the high complexity often associated with the procedure, it demonstrated an acceptable morbidity. In fact, we reported a postoperative complication rate of 21% and severe complication rate limited to 5.4% of the overall population. And we did not report any perioperative deaths. So this highlights that the secondary cytoreductive surgery can be performed safely in a well-selected patient group, balancing complexity and outcomes. So with this study, we identify important preoperative predictive factors for achieving complete gross resection that improve our ability to select suitable surgical candidates. And we introduced this simple scoring system that can correlate strongly with the surgical success, particularly for the patient with a higher score. For patients with a score of 0, who typically have extensive disease burden or an unfavorable recurrence pattern, are less likely to benefit from surgery. However, the decision must remain individualized. So we propose this scoring system, but we always have to remind that the decision between undergoing surgery or not has to be individualized, and we can consider to introduce the diagnostic laparoscopy to refine this decision. So in conclusion, this study provides an insight into the predictors of complete cytoreduction and offer a practical scoring system to guide patient selection. So while the negative predictive value remain a limitation, for the patient with a higher score, surgery should be strongly considered as a treatment, as the best treatment that we can offer this patient in the first recurrence of endometrial cancer. So thank you for your attention.
Excellent. Thank you so much, Virginia, for that introduction and a really excellent summary. And I wanted to just kind of like start the discussion with like an overview of the patients that come to you. So for example, and I'll start with you, Francesco Gemelli, that have a recurrence of endometrial cancer. And of course, obviously you have the scoring system, and it seems that there's a very good correlation with high scoring system and good probability of doing a successful surgery. But at what point do you introduce like the functional status of that patient? In other words, the patient may come in with a younger age group, single site of disease, but that patient looks kind of like malnourished and doesn't look like an ideal surgical candidate. Where do you balance that, and as you've seen that patient come into your office?
Yes, thank you for the question, Pedro. For sure, we consider performance status as a crucial element, also because sometimes we don't take the patients for surgery, but sometimes it's very hard to consider her also for chemotherapy, because if the performance status is no function, statistically, we did not found any significance of ASA score in order to predict cytoreductive surgery, like desktop trial, for example, reported. But we have only a trend, and we selected only those elements where statistically correlated with a prediction of complete gross resection. But for sure, performance in general is considered a basic element for considered surgery, either chemotherapy. Also because when we speak of chemotherapy in recurrent endometrial cancer, after the introduction of all the immunotherapy word, we have also to really see how is the performances of the patients.
Excellent, excellent. So again, I see that we have quite a number of people and that have joined our journal club. We're excited to have you. Thank you for attending, and please proceed and submit your questions. But as we traditionally do, we will start with some of the questions from our fellows, and we'll go first to Ali Strubhard in Salt Lake City.
Thank you, and congratulations on your wonderful study. My question is that you report on a simple and clinically relevant algorithm for the likelihood of complete cytoreduction. Will you or have you analyzed the model in regards to oncologic outcomes?
Okay, thank you for the question, first of all. Our goal is to create a clinical algorithm in order to really select patients, or better, not to select patients, but to consider the feasibility of a complete gross resection. So we want to underline the fact that if patients have a negative predictive value, we have to consider the possibility also in this to achieve complete gross resection. We only want to know if we are able to predict the rate of complete gross resection. I think it is crucial because nowadays we have to consider also for the oncological outcomes the relevant role of immunotherapy, not only for MMRD patients, but also for MMRP. For example, in Italy, we have the possibility to consider immunotherapy also for MMRP patients. So we have to consider this, first of all. Now, regarding oncological outcomes, we previously demonstrated in our journal, can say International Journal of Gynecological Cancer, like in our journal, that complete gross resection is the goal, and similar to that reported for recurrent ovarian cancer, when we are able to reach the goal of complete gross resection, we can have an advantage for the patient. For sure, as the editorial to this paper is showed in the International Journal, there is no randomized trial that support the use of surgery instead of chemotherapy or chemotherapy plus immunotherapy in recurrent ovarian cancer. But when we have the capability to achieve a complete gross resection, I think is a good way to select patients for surgery or not for surgery. So we know that and we push on that, especially for some particular pattern of recurrence, like nodal recurrence or hematological recurrence. It's different if we find a patient with celomatic recurrence with carcinomatosis where we can technically achieve a complete gross resection, but probably these patients should be selected for an alternative treatment, I mean a medical therapy. So we know that we previously published the paper comparing complete gross resection, suboptimal residual tumor, and chemotherapy, and we show that suboptimal have the same curves of chemotherapy. So our real goal is to find a method to select patients to a successful secondary debulking surgery in this pattern of patients. And when we achieve this, the prognosis also is, if in a retrospective series, seems to be better than only chemotherapy. All our data are in the pre-immunotherapy era. So we have also to consider this. I don't know if we will be able to design a randomized trial between chemotherapy with immunotherapy compared to surgery, like the desktop did. But we want to test to validate this score also in other series and try to really design a trial on this issue.
Great. Thank you for that thorough explanation. And I wanted to actually follow it up, Francesco, and at Gemelli, when discussing these cases in your tumor board, overall, of all patients who present with recurrent endometrial cancer, what percentage would you say are actually going to surgery versus going to immunotherapy or chemotherapy or non-surgical options?
If we consider all the patients, we have to consider that don't consider platinum-free interval, don't considering age of patients. So more or less, we have 20% of recurrence mainly, and of this, an half, so 10% can be considered for surgery.
Yeah.
Half and half.
So
But it's not a randomization, it's a
Yeah.
selection, pre-selection criteria. So for sure, in these patients, young patients with good performance status, with nodal recurrence, in my opinion, it's hard to don't consider surgery and start directly with immunotherapy, also with chemo. We have data on recurrent patient managed by immunotherapy. All the data, all the phase 3 trial are amazing about this impact, but the number of patients considered for surgery and sent for immunotherapy in the trial is very, very low. This is not well reported. So we consider patients not suitable for surgery.
Okay, great. So next question, we're going to go to Turkey. Mine Dages.
Thank you. And thank you for the excellent study, podcast, and the presentation. My question is, could incorporating diagnostic laparoscopy into the preparative evaluation for all patients further refine decision-making and improve the prediction of resectability outcomes? Thank you.
Yes, thank you for your question. Absolutely, yes. Incorporating diagnostic laparoscopy into the preoperative evaluation could play a significant role in the refining decision-making and improve the prediction of resectability. Especially if we consider the score, as we reported before, we had a quite amount of patients with a score of 1, in which we achieved a complete gross resection in 40–60% of the cases. So in this particular population, I think we believe that introducing the diagnostic laparoscopy could effectively ensure a better refining selection for these patients. So through the diagnostic laparoscopy, we can effectively assess the resectability of that patient and ensure the best treatment option that we can offer. Moreover, in our institution, the diagnostic laparoscopy is routinely performed, even in cases where we are quite sure that we can proceed with the bulking surgery, because through the diagnostic laparoscopy, we can first decide if effectively we can achieve the complete gross resection, so assess the efficacy of the debulking surgery. But beyond this, we can also decide the correct, the better surgical approach, deciding for minimal invasive surgery or laparotomy, and estimate the disease burden, so we can refine the surgical strategy, the approach, and effectively judge if the surgery is the best treatment option for that kind of patient. So yes, diagnostic laparoscopy won't add any delay in starting chemotherapy if the patient is not suitable for surgery, and will add for sure an advantage in selecting the right patient and decide the best treatment strategy. So yes.
Great.
Thank you.
And Virginia, as a follow-up question to that, if doing the diagnostic laparoscopy and assessing the low volume of disease or a single site of disease, would laparoscopic resection be considered still a good option at that point, rather than opening the patient to remove a lesion that you can easily remove by laparoscopy?
No, yeah, sure. Actually, we are analyzing in the same cohort of this study, we are analyzing the predictive factors for minimal invasive surgery. And I think we will present this data at ESGO in Rome, so you are all invited to come. Actually, laparoscopy seems to be a feasible option without decreasing the survival outcomes of these kind of patients. So yes, if we have a single site relapse, a nodal relapse, or a local regional relapse, actually minimal invasive surgery seems to be a good option that enhance the postoperative outcomes, of course, without increasing the postoperative complication, and most of all, without decreasing the survival outcomes.
Well, fantastic. We look forward to looking at those results in Rome.
Thank you.
And I hope the International Journal will get the first rights to that paper
For
as well.
sure. Thank you. I consider it an invitation.
Pedro, I'd like to add something about this, because in our institution, as you well know, diagnostic laparoscopy is a crucial element for advanced disease, in not only for ovarian cancer, for endometrial cancer, for recurrence in ovarian cancer, for endometrial cancer. So we have really to incorporate the laparoscopic approach as a diagnostic tools. Thank you to this approach, we can select patients to be managed directly by minimal invasive, or reconsider patients with negative score, but with a surgical field that in which complete resection is still achievable. So, especially in case with negative predictive score, diagnostic laparoscopy can be also considered. Excellent. If patients is young and can experience a good performance status.
Excellent. Very, very well. Thank you. So now we go to Kazakhstan, Raikan Bolat-Bekova.
Thank you. My question is, could you share with us the complication rate and if this is aligned with the existing literature?
Sure. Yes, thank you for the question. This was the secondary endpoints of our study. And when we look at the complication rate, we observed 14.5 intraoperative and 21.5 postoperative complication rate. No severe complication intraoperatively, and for the postoperative period, 5.4 complication with severe complication were reported with no perioperative deaths due to the surgery. So our goal is to have a low profile, a low rate of complication, and these numbers are in line with the literature. About surgical time, operative time, the median operative time was 200 minutes, 204 minutes exactly, and the estimated blood loss was less than 500 milliliters in more than 80% of patients. And our data are more or less superimposable to those reported in the literature, and also this data confirm that approach in selected patients can be performed without high grade of complication or high risk of morbidity in the postoperative period. So we confirmed in our respective studies the fact that for selected patients, more good is the selection, more is to do surgery, and less are the complications.
Excellent. And just as an additional comment, as I was thinking, now in these patients' records, do you actually are recording that score?
In the new one or the old one? Sorry.
No, in your patients now routinely, that a patient
Yes,
that comes in gets
we
a
calculate.
laparoscopic. So you actually are documenting the score was such and such.
Yes. In the MDT, where we discuss all patients, primary or on recurrent, we apply the score in order to prospectively validate in internal validation of the score.
Excellent, excellent, very well. So again, I'd like to point out that we welcome questions from the audience as well. So please feel free to write your questions on the chat. But we will then now go to Susanna Del Frati, also in Italy. So you're welcome to ask this question in Italian if you prefer.
Yes, it's possible for us.
Thank you for your presentation. I would like to ask do you consider a 5% rate of pelvic exenteration and a 10% rate of pulmonary resection in the group that undergoing secondary cytoreductive surgery to be acceptable in the era of immunotherapy? Thank you.
Yeah. So thanks again
Virginia, we'll take that first.
Bad question from our country.
I was going to say, leave it to the Italians to ask.
Thank Thank you.
So actually, we do believe that 5%, that these percentages, these rates are still acceptable. But I think that first of all, we have to really consider that the role of surgery in the recurrent setting of endometrial cancer still remain I don't want to say a cornerstone, but is mainly recommended from both ESGO guidelines and NCCN guidelines. So we cannot shift directly to immunotherapy, also following the guidelines. Anyway, the other things that I think we need to consider is that in all these wonderful studies that are evaluating immunotherapy, so the RUBY, the DUO-E, and all the trial, the rate of patients with the recurrence, with the first recurrence, was not the same setting. I mean, the enrolled patients were the one with the recurrence, but where the surgery was not considered the curative option. So what I do believe is that we cannot directly shift the results that we found in the immunotherapy trials. We cannot directly shift these results into this kind of patient, into these settings. So what I think we need to study and what we need to evaluate in the future, and I hope we will do it, is that we need to evaluate the role of immunotherapy also in the patient that can receive a surgical debulking. So we need to evaluate if immunotherapy can add, besides surgery, an advantage also in these settings. And the other things that I would like to stress is that the overall response rate that is observed in this trial is not of 100%. So in MMR deficient patient, the trial reported like a response rate of 45%, and in the MMR proficient patient of about 32%. So shift directly and eliminate surgery in this patient, I would not say that is safe. Of course, pulmonary resection can be, when the nodule is isolated, could be also, I don't want to say an easy surgery, but with a low morbidity rate. For exenteration, this makes more sense, of course, because we can at least try maybe with immunotherapy, and then let's see how the patient responds, and then maybe shift for surgery.
And Francesco, you wanted to add to that?
Yes, I can add that then when we have only metastatic recurrence, we consider surgery or cytoreductive radiotherapy as an alternative. And after the local treatment, I can say that surgery and radiotherapy are local treatment. We consider chemotherapy after with immunotherapy, because in Italy is allowed. I don't know if worldwide. And our feeling now is that we cannot avoid surgery when surgery can be done with complete gross resection. For sure, pelvic exenteration has less curative effect for endometrial cancer compared to cervical cancer, for example. So in that case, probably the adding of immunotherapy can change our way of manage these patients, not for oligometastatic local single or less than 5 metastases.
Yeah. So, Susanna, I think after that question, you will have no problems going to rotate a Gemelli whenever you want. You will be very welcome.
So thank you very much.
It actually also a question that came to mind for both of you, actually. Do you find that are you ever confronted in a situation where you may be potentially excluding patients from clinical trials by doing surgery? In other words, you're gonna leave them with no measurable disease, so then therefore that patient is not going to be a candidate for potentially a very good trial. Does that ever come up in discussion?
Yes, we are a research center, so for sure where we have trial for recurrence, we have also always to consider. But again, if we have another recurrence, see single nodal recurrence, and probably we can manage it by minimal invasive. In that case, surgery is the preferred approach.
Okay, very well. So now next question, we're going to a much easier question from a nicer country in Spain, in Malaga. So Jose Carlos Vilche.
Thank you, Pedro, and thank you for your presentation. Okay, I have some questions. How were the recurrence defined in the different main tests? What criteria were established for nodal recurrence? Were there any false positive? Thank you so much.
Thank you for the question. We use both CT and PET-CT, I mean. For CT, we use the classical RECIST criteria in the presence of new nodal suspected nodes. And for PET-CT, we limit it to the focal uptake that is suggestive for metabolic activity. About nodal recurrence, we consider morphology. Our radiologists consider morphology, presence of necrosis, and extensively a short axis diameter greater than 1 centimeter that is normally accepted as a threshold for lymph node involvement. To ensure accuracies, all cases were reviewed in our MDT, both by nuclear medicine doctor and radiologist, and we discussed it with them, and we really need this one because if we consider patients sent to our center, sometimes we have false negative or false positive, so we need to review patients radiological analysis. Regarding false positive, it's a good question. It is important to know that these cases were not included in the final analysis, so we consider only patients in which we do surgery and we have diagnosis of recurrence. The risk of false positive cases is not unrelevant, but we limited this number thanks to the relationship with our colleagues.
Now, when considering the resection, going back to the point of patient selection, similar to how we view patients with ovarian cancer, what are criteria that you both as surgeons will look at an imaging and say, other than extra abdominal disease, but disease within the abdomen, that you look at the imaging and you say, I can't, I'm not going to be able to resect that?
I can answer to the question. Before desktop in ovarian cancer, selection criteria are very strict. Now, since we have data that support secondary cytoreductive surgery followed by chemo, also in some cases that previously we do not consider for surgery, we push a lot on surgery in recurrent ovarian cancer, platinum-sensitive ovarian cancer. As you know, there are absolute limitations for complete growth resection like mesenteric retraction, but we are in the case of celomatic recurrence. So I think the real issue is if we have to do a lymphadenectomy, we have 2, 3, 5 nodes in the same area we can do. If we have a gross retroperitoneal disease, we cannot consider surgery. So I think we have no absolute limitation or elements to select. It's similar to what we do for ovarian cancer. When we have the technical feasibility, for sure, in this selection criteria, age of the patients, performance status help us to select patients.
Excellent. So now we're going back to Italy for another question from Roberta Masobrio.
Thank you and congratulations again. Does previous radiation affect the indication for surgery? And does it influence the choice between an open or minimally invasive approach?
So, yes, of course, we always consider radiation first as an option, especially for the local recurrence and the vaginal recurrence or the local regional one in radiotherapy naive patients. Regarding the, by the way, we have really small data and retrospective data that directly compare radiation therapy versus surgery. Some others show that actually surgery seems to be better than radiation therapy when we directly compare the two kind of treatment for the single relapse. By the way, this data needs really to be taken with caution because are very small, came in from very small number of patients. So when we have to consider what can we do in our tumor board, usually we try to treat with the radiation patient with a single site relapse, vaginal relapse, or patient that, for example, would need an exenteration. So maybe in that case, we firstly decide to try with the radiation therapy, and we can leave the surgery like as the last option we can offer to that patient. Concerning the surgical approach, so minimal invasive versus open surgery, actually the radiation therapy, we do not believe that there is a strict contraindication that enable us to operate through a minimal invasive approach. In fact, as we were saying before, the previous treatment with radiation does not seem to be a contraindication for minimal invasive approach. Of course, the quality of the tissue, the type of radiation therapy that the patient received, and also the field of the radiation will influence the capability of proceeding with the minimal invasive approach, and we can try to proceed with minimal invasive or try to shift with the open surgery actually, but it is not a strict contraindication. And in case of, for example, nodal recurrence, I think the minimal invasive approach is actually a really good option, even in treated patients, but of course depends also on the quality of the tissue, on the type of the patient, and other factors that we cannot predict with the current examination that we have.
And Virginia, as a follow-up to that, in the patient that you consider that based on the imaging, based on the tumor board evaluation, that most likely you are going to be able to debulk this patient by minimally invasive surgery, do you schedule that patient for robotics, or do you schedule for laparoscopy, or does it matter?
Actually, another factors that came out that we prefer the minimal invasive approach is the BMI. We try to do the minimal invasive approach in the obese patients. So when we have a BMI over 30, between laparoscopy and robotic approach, we are not able to identify which are the factors that make us decide to one or the other. But as the school, we usually do the robotic surgery in obese patients, and we proceed with the minimal invasive with the laparoscopic approach in the other. So maybe the robotic approach can help in some way, but of course, in the obese patient, we will decide for the robotic approach. In the other, we can do both laparoscopy or robotic approach.
Okay. And then as a follow-up question to that, in the patient that you complete the cytoreduction by minimally invasive surgery, be it laparoscopy or robotics, are those patients routinely staying overnight, or they go home the same day?
No, actually they're staying, yes. They're staying, but this is also for the recurrent factor, for the recurrent surgery, they're usually staying like a few days. In our data, the median hospital stay is like 2 or 3 days, consider also the day of the surgery. But this is also a I don't know how to say, it's like the state, the Italian state make the patient.
Our national cancer health system does not allow us to consider no night for surgery for recovery. So
they
we
might
need to
stay
do
like 2 nights.
And also because, as you probably mean, we try to work a lot on the ERAS also in these patients, but since most of the patients are not in our region, in Rome, I mean, sometimes time to discharge is not equal to time to possibility to go home. Is a national cancer health system trouble.
Okay, very well. So we'll go back to Spain. Elena Rodriguez Gonzalez will ask the last question from our fellows.
Thank you. Based on what was observed in the study, which criteria would you propose to roll out surgical treatment in patients with recurrence of endometrial cancer?
Okay, thank you, Elena, for the question. Based on our findings, we have different scores. If we have score as 0, we have to know that these patients are the less likely to be candidates for successful surgical treatment. This is because these factors are strongly associated with suboptimal surgical outcomes, specifically extensive disease burden in case of diffuse carcinomatosis, because we consider hematologic or nodal diffusion as a positive score, or mixed pattern of relapse. All these characteristics significantly reduce the chance of achieving an optimal debulking. Concerning local regional recurrence, we must acknowledge that RT radiotherapy should be considered as an option, not only for external beam, but also for stereotactic therapy. That say that it's important to note that the score has a relatively low negative predictive value of 43.8%, but it does not completely exclude surgery as an option. When we wrote this manuscript, at the end of the paper, you can find that we can have an algorithm, score 0 medical therapy, score 3 surgery, 1 to 2 discussed with the patients. I think that thank you for the podcast and for the webinar that we are doing now, we can reflect on our data, and we really can say that use this score only to know what is in objective rate the possibility to have a complete cross resection. Don't select patients only for this score, because what we learn from our experience is also that if you have a negative score, but the negative score is in a young patients, and you consider the possibility to really have a complete cross resection, mainly also by minimally invasive, do a diagnostic laparoscopy and try to do this, especially if she is MMRP patients, in which probably immunotherapy is not over the world available. So I really thank Pedro for the opportunity to rethink about our paper, because when you publish a paper, you consider that the paper is end. The paper still lives in our mind, and thank you for the observation. We move on and we try to do the next paper.
Absolutely. No, thank you for that. And as you know, the paper keeps going. If you publish it with the International Journal, it just continues as well. So I really want to thank you both, obviously, for this discussion. I really, truly enjoyed it. I have one last question. I want you to please be very thoughtful in how you answer this question, because I think it's the most important question. Moving forward, what will this score be called? The Vargiu score or the Fanfani score?
Vargiu, because all the score by Gemelli are by women. As you know, we have forgot this score, so we cannot have Fanfani score. I'm not allowed to have the patent of the score.
Very well.
Double V score.
W score.
No, W score.
From here on forward, we can refer to it as the Vargiu score.
There is a claim hand, Hussein.
Oh, Hussein, sorry.
Yeah, hello. Yeah, one from Germany. I have two questions. The first one, after a cytoreduction surgery, if you get R0, as you have no tumor mass microscopic, do you want to give adjuvant radiation or chemotherapy again? And especially with the patient with DMMR, would you give immune therapy after the surgery with microscopic?
Yes, we do. Yes, we do. Not radiotherapy, but chemo plus immuno, because we can do in Italy. So especially
Okay.
for MMRD, after complete growth resection, we consider chemo. We cannot call as adjuvant because our medical oncologists are not agree with the name adjuvant, but
Okay.
we consider with post-operative chemotherapy.
Post-operative chemotherapy. Thank you very much.
With immuno.
Yeah, thank
You're
you.
welcome.
Well, thank you again. Thank you all for joining. Thank you for sharing your detailed discussion on the VARGIO score. And we're really very grateful that you submitted your work to our journal. Thank you for your time and your effort, and certainly for sharing your thoughts with us as well. We're really very grateful. Fantastic job to both of you. Before I depart, I also want to invite everyone to our podcast and journal club for next month, in the month of January, where we're going to be featuring the sub-analysis of minimally invasive versus open surgery in the SHAPE trial. Marie Plant will be with us, and that will be also, I think, very interesting. I want to thank everybody and wish everybody a great holiday and Buon Natale for those of you in
Thank
Italy.
you.
Thank you.
Buon Natale.
Buon Natale. Thank you.
Thank you. Bye-bye.
Bye.